Good morning to one and all. On behalf of IAP technical team, I welcome to all participants and I also welcome to our today's speaker, Dr. Snigdha Mehta ma'am. Welcome you ma'am. Before hand over this webinar to our today's moderator, Dr. Vaibhavi Ved ma'am, I request to all participants, please subscribe our IAP YouTube channel. Thank you. Hand over to Vaibhavi ma'am.
Thank you so much, Alopi madam. Hearty good morning to everyone. It gives me immense pleasure to welcome you all on this platform for today's session on Partners for Life, Pelvic Floor and Diaphragm by Dr. Snigdha Mehta madam. This event is organized by IAP Women's Cell, Rajkot District, Gujarat. I take this opportunity to thank the organizers of this event, the central IAP team, the entire IAP WC team, Dr. Ruchi Vaishne ma'am, National Head, Dr. Pooja Kamble ma'am, Zonal Head, Dr. Bhavna Gadvi ma'am, Gujarat State Coordinator, Dr. Devangi Vaishnav ma'am, Gujarat State Sub-Coordinator, along with IAP technical team, Dr. Alopi Oza madam. Let me introduce myself to you all. I am Dr. Vaibhavi Ved, Chief Consultant Physiotherapist, Arham Multi-Speciality Physiotherapy Center, Rajkot, and I am serving as IAP Women's Cell District Coordinator, Rajkot. I request all the participants before starting the webinar to raise your questions and queries of the webinar in the chat box in the Zoom, as well as we are streaming live on YouTube IAP India channel. At the end of the webinar, we will be discussing and interacting all the questions from your side. So that will help us for the smooth conduct of this webinar. Once again, please write down your questions and queries in the chat box and we'll solve it at the end of the session. Okay, so first of all, on this relaxing Sunday morning, when I see this enthusiastic people joining the webinar with a craving to learn something new, it brings to me sharing with you all that an investment in knowledge pays the best interest. And for us here, you all will agree, we have nothing to invest other than our time. And we are going to get best interest today. So before we commence with this session, let me just give an introduction to this magnanimous personality we have with us today, Dr. Snigdha Mehta ma'am. She has received her teacher's training in women's health from pre- and postnatal exercises from Elizabeth Noble Madam. Madam is only physiotherapist from India, certified by American Physical Therapy Association in 3 obstetrics and 3 pelvic physical therapy courses in USA. She has received her training in musculoskeletal and manual physiotherapy from more than 20 internationally renowned physiotherapists like Brian Mulligan, Jenny McConnell, Mackenzie's Institute, and many such more. She has been offered scholarship by APTA for pelvic pain and bowel dysfunction in 2019 in USA. And I would like to share one more thing, that she has conducted more than 30 workshops in obstetrics and physiotherapy, women's health for teachers and clinicians. And I'm fortunate to be a part of one of them and learn from her. She has a vast clinical experience of more than 40 years with treating thousands of orthopedic patients, elite athletes, females with pelvic pain problems, postpartum and antenatal female. So I hand over this session to our respected Snigdha madam. Over to you, madam. Ma'am, sorry to interrupt you. Your mic is off, madam.
Oh, yeah. Can you hear me now?
Yes, madam.
Okay. So thank you so much, Alopi ma'am and ma'am, for this wonderful introduction and conducting this webinar and inviting me. And I thank IAP and IAP Women's Cell Rajkot for inviting me. It's my pleasure today to talk to all of you. So shall we begin with sharing the screen?
Yes,
Yes,
ma'am.
ma'am, you can share.
So I hope you can see the screen. In any time you can't see the screen or you can't hear me, please let me know, Alopi and Vaibhavi. Otherwise, I'll just proceed with my presentation.
Okay, ma'am.
So
You.
yes, a very interesting topic for today is Partners for Life, Pelvic Floor and Diaphragm. Being an obstetric and pelvic floor physiotherapist and also trained in orthopedics and musculoskeletal physiotherapy and in manual therapy, I think that this combination of training has benefited me a lot, and I strongly recommend that all of you should train in both these aspects of physiotherapy, and it gives a much more complete picture of treating a person. So most of us are not conscious of the way we breathe, and even less so how it may affect our pelvic floor. Actually, our respiratory diaphragm and the pelvic floor share a very intimate relationship, both structurally and functionally, because they are bound by fascia, by muscles, and bony connections. That is why we find non-optimal breathing patterns in patients suffering from pelvic floor dysfunction and pelvic floor dysfunction in those having breathing disorders like asthma, COPD, etc. We need to learn to modify and regulate the breathing, maybe which maybe at first seem unrelated to a pelvic floor problem. But pelvic floor muscles play a very important role in the physiology of breathing. Pelvic floor muscles not only support the pelvic organs, but also participate in the dynamic control of intra-abdominal pressure together with inhalation and exhalation. Often we in pelvic rehab bemoan that the fact that the pelvic floor is not given enough attention it deserves, when we know that it really is the answer to a lot of neuromusculoskeletal problems. But I do believe that we as pelvic health specialists are just as guilty of not paying enough attention to the roof of the abdominal canister, the diaphragm. So let's revise the abdominal canister. The abdominal canister, of course, consists of our diaphragm, to which is attached the psoas fascia, and the psoas is attached to the pelvic floor. Then, of course, we have the quadratus lumborum on the lateral arcuate ligament, and all of these muscles play a very important role besides the psoas, the iliacus, and many other muscles that we'll be talking about play a very important role in the abdominal canister. The transversus and the multifidus are the other muscles that are very important. And of course, we have our intercostal muscles, the external and the internal intercostal muscles, the innermost intercostal muscles, the sternum, the ribs, all of these again play a very important role. The piriformis and obturator internus, which are connected to the pelvic floor, if there is a dysfunction in any of these muscles, then again we get pelvic dysfunction and maybe breathing problems too. The pelvic floor muscles, of course, consists of the levator ani, which is the iliococcygeus and pubococcygeus, and the coccygeus muscles. All of these put together make the abdominal canister. So what is optimal breathing? During inhalation, diaphragm contracts and moves downward. The lumbar spine arches slightly. The external intercostals contract, causing the ribs to expand. The pectoral muscles contract, lifting the mid-ribs. The scalene muscles contract, lifting the top of two ribs. During inhalation, the diaphragm relaxes, moving in and up like a dome. The lumbar spine flattens a bit. The internal intercostals allow to move back towards the midline. The pectoral muscles relax, lowering the ribs. The scalene muscles relax, settling the top of the two ribs. So tension-free diaphragmatic breathing activates the relaxation response of the parasympathetic division of the autonomic system, and correct breathing is a great way to start both and treat both an underactive and overactive pelvic floor. So the diaphragm and the pelvic floor have a very symbiotic relationship and mirror each other. When we inhale, our diaphragm goes down to create a pressure to draw air into the lungs. So when the diaphragm descends, the pelvic floor also relaxes and goes down. On exhalation, when the diaphragm is elevated, the pelvic floor is also elevated. What is the function of the pelvic floor musculature during exhalation? So during exhalation or coughing, the PFM contract together with the abdominal muscles and increase the intra-abdominal pressure, helping the diaphragm move upward. So exhalation actually initiates as low as the pelvic floor and diaphragm is pushed. Hence, the pelvic floor musculature is a key player in the generation of intra-abdominal pressure and plays an important role in respiration. What about inhalation? During inhalation, the pelvic floor muscles relax to help the diaphragm move downward, allowing inspiratory flow to increase. So not only the PFMs play an important role in physiology of breathing, but they also support the pelvic organs and participate in dynamic control of intra-abdominal pressure together during inhalation and exhalation. The functional synergy between these muscles is very important for understanding how to provide better pelvic floor health, including control of incontinence, pelvic pain, and bowel dysfunction. Without understanding this synergy between the diaphragm and the pelvic floor, we cannot completely treat these problems of incontinence, pelvic pain, and bowel dysfunction. The muscles of quiet respiration, inspiration, we all know. The primary ones are the diaphragm, intercostals, levator, costorum, and the accessory ones are sternocleidomastoid, serratus posterior, iliocostalis, subclavius, pectoralis minor. The diaphragm provides 70 to 80% of the inhalation force. The primary muscles of respiration, as you see in this picture, I've already mentioned. I've just given you a picture because pictures give you a good memory of the musculature of area. What are the accessory muscles of respiration? I've already told you that. So why are they important? The accessory muscles, they're important because they're recruited during times of exercising, when we run, when we need those accessory muscles of respiration because we have increased metabolic need. And also they could be dysfunctional in a normal restful breathing pattern. With those with problems of respiration and those with problems of pelvic floor. Some of these muscles which are overactive in this person and cause problems of pelvic floor, or he has pelvic floor problems and therefore these muscles have become overactive. So why are diaphragmatic movements so important? The normal diaphragmatic movements enable and abdominal cavity of rhythmic stimulation like an internal massage, which is important for maintaining normal pelvic lymph and blood circulation. Pelvic pain and congestion have been correlated with chronic muscle tension, chronic hypoxia, as well as accumulation of metabolites such as lactic acid and potassium. Hence, if one has a problem with the respiratory diaphragm, it's likely one will have a pelvic floor problem. And if one has a pelvic floor problem, it is very likely that the diaphragmatic is affected. Thus, the rehabilitation of the pelvic floor will be enhanced by retraining normal physiological breathing, postural re-education, manual therapy techniques. This is all beside the actual pelvic floor muscle energy techniques, trigger point release of the pelvic floor muscles. So today we will talk about specific pelvic floor techniques. We will talk about these 3 points more. Assessment of patient with pelvic floor dysfunction is the first thing when a patient comes to us. So we always take a thorough history, we observe the patient, and then we examine the patient thoroughly. In case of pelvic floor dysfunction, listening to the patient is very, very critical, especially because they have a lot of emotional overlay of their problems, and how they tell you their story is extremely important to for better outcomes. This is one of the questionnaire we can give to them. This screening tool to detect patients with hyperventilation complaints, and a score of over 23 out of 64 suggests a positive diagnosis of hyperventilation syndrome. And then we have a self-evaluation questionnaire, and this will give us some idea of how this patient evaluates his own breathing. Posture is extremely important. So when we observe the patient, ideally the posture should be exactly like it is in the first picture. The ribs should be stacked over the pelvis and over the knee and over the ankle. But some patients come with this kind of posture. In this posture, if you notice that the thoracolumbar extensors are overactive, the abdominal muscles are underactive, and the hip flexors are overactive, whereas the gluteus are underactive. In this guy, the thoracolumbar extensors are not very active, but lumbosacral extensors are very, very underactive. The upper abdominals are overactive, whereas the lower abdominals are underactive. And we see these kind of postures regularly in our clinics. And this is the first thing that we observe, and we must deal with this posture and correct it like you see in the first diagram. Second thing we should do is assessment of the breathing pattern, and this is the high-low test. The therapist observes the patient from the front and from the side, whether the patient is having a predominantly abdominal or lateral costal or paradoxical pattern or upper chest, or it is a balanced pattern of the lateral costal, abdominal, and the thorax. We also observe the patient from the posterior aspect, and if dominant movement is the upper rib cage, which would be we come to know from a more vertical motion, and if the motion is more lateral, then probably it's the lower rib cage. We will have a more lower rib cage motion than the upper rib cage motion. Breath holding test is another important test that we should do. So there's no agreed breath time. And this is done a lot with the done, but we'll not go into detail of the yoga asanas, but we'll talk about this breath holding test. So there's no agreed breath holding time, but it can be a very useful clinical point of reference. Patients who hyperventilate seldom hold their breath beyond 10 to 12 seconds. So as the patient does normal exhalation, he should be asked to hold his breath until he experiences a definite sensation of discomfort and a need to breathe again. Or he has a first involuntary respirative experience. Normally, he should be able to hold his breath for 25 to 30 seconds. That's considered normal. But less than 15 seconds represents low tolerance to CO2. This is an excellent test done for divers who dive into the deep sea. But usually we don't do this test very often, but this test gives us a good indication of the breathing capacity of an individual. We, of course, have to assess all the spinal restrictions, the rib mobility or restrictions, the force closure of the sacroiliac joint by the active straight leg raise test. We have to test all the weak, underactive, and tight and overactive muscles, which could be the neck muscles, which could be the thorax muscles, which could be the abdominal muscles, or it could be the lower limb muscles. So it's a very, very detailed examination that we need to do. I'm not going to go into every single because we are all well qualified physiotherapists who know most of the examination. So some of the muscles that we should test are the psoas, the iliacus, the quadratus lumborum, piriformis, hip adductors, rectus abdominis, abdominal obliques, scalenes, intercostals, stereomastoid, levator ani, gluteus maximus and medius, pectoralis major and minor. These are some of the muscles that we need to test. I'm going to talk of little unusual muscles that are not very commonly tested. So this is the test for the posterior fasciculus of the psoas, and this is a very important muscle which provides stability to the sacroiliac joint. How do you test it? By gently distracting the leg longitudinally and asking the patient to pull the hip back into the socket gently. There should be no pelvic movement and there should be no spinal movement. If the patient is unable to do it, we note it down that the posterior fasciculus of the psoas major is weak. This is another test we don't do very commonly, testing for activation of deep sacral gluteus maximus, again influencing the stability of the area. So you have to visualize, the patient has to visualize trying to pull both PSI horizontally towards each other. There should be a palpable contraction of the deep sacral gluteus maximus and not of the lateral gluteus maximus. So you put your hands, so my thumb is palpating DSGM and not, and my fingers are palpating the lateral gluteus maximus. There will be a co-contraction of the multifidus, transverse abdominis, and pelvic floor when we test these muscles, if done correctly. Education, as we always have all our patients, we need to educate them. So we discuss the assessment findings, tell them that what are their weak areas, what are their tight links in the body, which are causing problems with their breathing and the pelvic floor. We have to also teach them elements of appropriate breathing. And before we teach them, we have to make them understand what is the meaning of appropriate breathing. And we also have to make them understand external situations and internal states of thoughts, emotions that may trigger altered breathing. So talking to the patient, educating the patient is the first thing that you do when you treat the patient. So what are the advantages of controlled breathing? We have to talk to them in their language. But since I'm talking to physiotherapists, I will talk in a more scientific language. So the advantages of controlled breathing is promoting a calming effect by increasing the parasympathetic activity. It ensures that the level of carbon dioxide in the bloodstream is optimal so that the pH stays in normal range. It's amazing how controlled breathing reduces our pain threshold. And this we see in our sages who stay in the Himalayas, even in the coldest weather, and they can tolerate that coldest weather, or they walk on those sharp iron pills, and yet they don't seem to get pain. The myofascial trigger points are not stimulated with good, relaxed, deep breathing. The abdominal circulation, the blood and the lymph is stimulated by the regular diaphragm action. Pelvic muscles participate in the rhythmic contraction and relaxation together with the diaphragm, which we always want. Heart rate variability is enhanced by breathing at a particular frequency. The parasympathetic nervous system becomes stronger relative to sympathetic because of prolonged exhalation that the controlled breathing. So just in case somebody doesn't know what is heart rate variability, HRV is the physiological phenomena of the variation in the time interval between two consecutive heartbeats in milliseconds. A normal heart, healthy heart, does not tick evenly like a metronome, but instead, when looking at the milliseconds between heartbeats, there's a constant variation. And higher the variation, the better is the heart rate. What are the other advantages of controlled breathing? In case of pelvic pain, small changes in breathing can affect pain mechanism by inhibiting pain through descending inhibitory tracts. It raises the endorphins and dopamine. It interrupts cycles of worry and it lowers cholesterol, CCK, which is a gut hormone, which helps in the digestion, and adrenaline. Reduce sympathetic output to trigger points and resumes rhythmic stimulation of viscera and pelvic floor muscles. Teach control of breathing. So few points. We should always teach smooth and rhythmic breathing in which the ratio of inhalation to exhalation is 1:2. Teach slowing down the breathing rate to 20 to 30% below whatever is at that moment. Automatically, the tidal volume enlarges to compensate for the reduced rate. If all goes well and the patient has grasped and is able to reduce the rate by 20 to 30%, and his exhalation is double the inhalation time, then we can teach him to reduce the rate to 6 breaths per minute without straining or gasp, which is not very easy, but it is trainable. Also, we teach abdominal breathing and lateral expansion of lower ribs. This will usually help regain a natural breathing style and relieve overuse of chest and neck accessory breathing muscles. We should encourage daily practice, morning and evening, of breathing exercises to reinforce new learning. The inhalation and exhalation should be repeated for not less than 30 cycles. So what is the position? Brugger has given a very good position to teach diaphragmatic breathing. So during inhalation, external rotation of the shoulder tends to inhibit the activity of the accessory respiratory muscles. And as this girl is sitting on the stool and she's inhaling, Her hands are very comfortably down, and to inhibit her accessory respiratory muscles, she externally rotates her shoulder when she inhales and relaxes her shoulder back to neutral when she exhales. If the pelvic floor muscles are overactive or super tight, and if they're not able to appropriately relax, inhalation is the key. Teach them pelvic floor muscle relaxation while breathing in, with an awareness of lengthening of the pelvic floor, like telling them to drop their pelvic floor. This will help immensely in problems of vaginismus, dyspareunia, vulvodynia, functional constipation. Normally, very often we make the mistake of telling them to breathe out as they relax their pelvic floor. So breathing in as you relax the pelvic floor is the more important information that I would like to give you. If the pelvic floor muscles are or weak, teach them pelvic floor muscle activation with an awareness of the natural elevation and lifting of the pelvic floor while breathing out. This will help them with problems of urinary incontinence, fecal incontinence post-surgery, pelvic organ prolapse. So the lifting should be towards the pubis and towards the head of the pelvic floor. Slow deep breathing exercises sets up a pelvic floor diaphragm rhythm done for at least 5 to 10 minutes several times a day. This will help in those with problems like pelvic venous congestion, irritable bowel syndrome, pelvic pain, and people with low pain threshold, fibromyalgia, irregular periods, endometriosis, interstitial cystitis, or pelvic painful bladder syndrome. Posture, of course, has to be retrained. We assessed the posture earlier, and now we have to retrain it to get the erect posture that this guy has. So what can we do to help both breathing and pelvic floor? Normally, the ribs are stacked over the pelvis, but if the ribs and pelvis aren't well aligned, then our diaphragm and pelvic floor are at a disadvantage and cannot work properly. So to have better alignment, the weak muscles need to be strengthened and the tight muscles need to be stretched. This is one of the exercises we can do for thoracic extension by putting a roll under the thoracic spine and flexing the pelvis. Manual therapy is very, very handy, extremely useful, and we can do different myofascial techniques for restrictions. We can do joint mobilizations. We can do many other kind of techniques, like we can do taping, we can do this respiratory diaphragm release. So respiratory diaphragm release, the purpose is to release excessive tone in the diaphragm. After examination, we find that the diaphragm does not seem to be moving efficiently. Patient can be in the crook-lying or seated position. The therapist uses the hypothenar eminence to come under the ribs, and during exhalation, the therapist deepens contact with the diaphragm, pushing the fingers underneath the diaphragm. And this can be done several times gently, and it helps in releasing the excessive tone of the diaphragm. We should be doing 2 sets of 10 deep breaths with 1 minute interval between sets. This is another way of positional release of the diaphragm, or the strain counter strain method. So we put one hand on the diaphragm and the other exactly behind the posterior aspect, and we do a slow release of the diaphragm. And this is for a slow release of the pelvic floor muscles. by putting the hand over the pelvis, over the pubic area, and the other hand just underneath, exactly underneath the upper hand. How do we release the excessive tone in intercostal muscles? So that we can use our fingertips or thumb glides. We can glide them very gently on the intercostals of the posterior, lateral, and anterior thorax. And once we find that there are certain areas that are tighter or the rib alignment doesn't seem to be, we can do trigger point are noted, and we can do various manual therapy protocols like myofascial release or trigger point release methods to release those points. This is a good exercise that can be done for intercostal muscle release. Psoas is a very often a culprit of poor circulation or poor pelvic floor dysfunction. We can do myofascial release with our hands over the psoas muscle. We can use the Thomas test for releasing, accessing and releasing the psoas, and we can do an exercise like this for releasing the psoas. So we can use various orthopedic methods, manual therapy methods for releasing these muscles if they are tight. Quadratus lumborum exercises, we all know, can be done in many ways. As you see in this picture, the quadratus lumborum in the first picture is being stretched on the left side. Here too, it is being, oops. Here too, it's being stretched in the second picture on the right side, and in the picture on the right side again. Scalene muscles are necessary for quiet respiration, but sometimes they get overactive, and that's why a myofascial release of these muscles helps a patient to breathe much better. I did talk about the posterior fasciculus of the psoas major. So the way we test the patient, exactly the same way we treat them to activate their posterior fasciculus of the psoas. And this is also the same way we teach them to activate the deep sacral gluteus maximus. Scar tissue can be a big problem, and we often ignore it. So it is very important to assess if there is any kind of a scar tissue in the body, whether the patient has had surgery, whether the patient has had accident, because years down the line, scar tissues can give you big problems. So because scars may have adhesive properties that compromise tissue, altering proprioceptive input, leading to often protective postural patterns and pain syndromes. The scar tissue release should be included always in the examination and treatment. Very often I get patients with cesarean sections, and so many years down the line, they may get pelvic floor problems, they may get shoulder problems, they may get back problems. So it is always advisable that, for example, after a C-section, after 8 weeks, and after the tissue scar has healed completely, we should teach the patient as a regular measure to release their scar tissue. What is the time required to normalize breathing time? It doesn't come very easily. Breathing habits take a long time, and depending on the chronicity of the problem, evidence suggests that 6 weeks to 6 months may be required to normalize breathing habits. Not only physiotherapy, but yoga, qigong, tai chi, all help in postural improvement, in breathing improvement, and in pelvic floor improvement. So I find that we physiotherapists should learn these techniques and incorporate it into our treatment methods when we are treating our patients. What are the other factors that contribute to restricted abdominal movement during breathing? Very tight clothing. A lot of people wear tight clothing around the world. Previously, in an era in the Western world, it was the corsets. It was fashionable to have a very, very tight corset to show a very thin waistline. But now we can see tight waist belts, tight pants, or a lot of people wear slimming underwear to hide their abdomen. And especially this is applicable to a lot of celebrities. Over time, these people may not be able to activate or relax the lower abdominal muscles during respiratory cycle. So it is not recommended to wear these kind of tight clothings around the abdomen. A lot of people are worried about self-image. So they constantly keep pulling in their abdomen. Also, sometimes we give the wrong clue that pull in your abdomen, keep it pulled in and do all your exercises. No, this is not true. We cannot keep pulling in our abdomen. The abdomen goes in only when we breathe out. We should not keep it pulled in when we breathe in. So this is again very, very, very prevalent amongst the celebrity clients, and we should train them not to do it all the time. It's a defense reaction very often. The person unknowingly tenses the abdominal wall, a flexor response, in order to, because they have pelvic pain, and to inhibit the movement of the abdominal wall to protect themselves from experiencing pain. This could happen prior to abdominal surgery, surgery, or it could happen after an abdominal injury or surgery. It could happen when they are getting abdominal pain, like in an irritable bowel syndrome. They could be getting pelvic pain, like pelvic floor pain, and they would have a defense reaction of taking the abdomen in and flexing, or they have low back pain and they do this action. So this can also cause dysfunctional breathing patterns. There are some people who are unable to engage their abdominal muscles because of lack of muscle tone. And this we often observe in older people and those leading very sedentary lives, or women who've had multiple babies, or those with large abdomen. The resulting breathing pattern tends to be shallow, rapid, irregular, and punctuated with sighs in their chest. And hence, it's a dysfunctional breathing pattern. So correct breathing is the missing link in our treatment methodology of pelvic floor dysfunction. Beside manual therapy techniques and exercises that are recommended for pelvic floor dysfunction, we also must teach every single patient correct breathing technique. Integrating and coordinating the use of pelvic floor with breathing is an important strategy for activating the deep myofascial system of the abdominal canister and the key to gaining optimal control of the pelvic floor. Begin with the diaphragmatic breathing, then move to the pelvic floor. So what's the take-home message for today? With pelvic floor overactivity and or pain problems, beside doing some internal release of the pelvic floor and other affected muscles that we talked about, we should cue them to inhale all the way down to the pelvic floor, relaxing it. To improve pelvic floor contraction or activation, we should cue them to draw up the pelvic floor, up and in, cranial lift and lift towards the pubic symphysis while they are exhaling. Incorporating the corresponding strategies into activities of daily living and regular exercises can help individuals improve function and reduce symptoms. Thank you. Okay. So now we can have some questions, Vaibhavi, if there are any.
Thank you very much, madam. Ma'am, we'll have few questions right now. Shall we start with it?
Yes, please.
Okay, madam. Madam, first question is, how does breathing pattern is useful in endometriosis?
I did talk about the deep, relaxed, rhythmic breathing that helps in endometriosis, because in endometriosis, usually the parasympathetic system needs to be stimulated more. So that produces a relaxation response. Beside all the other treatment of manual therapy, exercises, we must also teach I treat a lot of endometriosis patients, and each and every one of them, I teach them correct posture and breathing techniques beside the other things that we do. So deep, slowing down the breathing helps relax them, and their pain threshold immediately improves a lot. So that's how it helps. It cannot help in the disease. None of these treatment will help in removing endometriosis, but it helps in the quality of life of the patient.
Okay, madam. Madam, our next question is, can you please repeat the pelvic release technique?
Pelvic release, which one was she asking?
Madam, we had in the
relaxation of the
presentation.
pelvic floor? The pelvic
Madam,
floor.
the manual release of the pelvic release, pelvic muscles.
Manual therapy, we do an internal pelvic floor examination, and we can manually by digital palpation, do internal digital palpation. We can release the levator ani muscles, the pubococcygeus, the iliococcygeus muscles, and we have to do an internal release of them.
Madam, the next question is there any difference in breathing exercise with patients with stress urine incontinence?
Yes, so stress urinary incontinence have to be taught the NAC technique, K-N-A-C-K, NAC technique. That means they have to, every time they cough, they tighten their pelvic floor muscles so they don't leak. They have to be taught that technique. So every time they cough or they sneeze or they lift heavy weights, the stress incontinence happens, or they jump. And that is why the NAC technique is tightening the pelvic floor as they are coughing or jumping so that they do not leak.
Okay. I think, madam, regarding the pelvic floor release technique with which the participant had asked for a repeat, actually, madam, she's discussing about how to place the hand, the right hand over the pubic area and the left over just underneath.
Oh, that one. Okay. Yeah. So this is just feeling with the hands, the tension in that area. And it's a very, very gentle technique. There's no pressure. You just put your hands there, one above, one below. And as you put your hand, you wait for the release of the muscles. And that's an external technique. Sorry, I thought she was talking about the internal technique. Okay, so so you just place the hand, and as you play, it's the myofascial release technique. The very gently, slowly, you will find the muscles getting released externally.
Okay. Madam, I had one question. My question was that, is there any role of pelvic floor muscle in COPD patients?
Yes, of course. Every patient with problems of breathing, whether they are asthma, they are COPD, all of them have to be taught good breathing techniques. Or we always do that, right? We always teach them good breathing techniques. But beside that, we have to incorporate their pelvic floor muscles into the breathing technique. For example, when the diaphragm goes up, the pelvic floor muscles should naturally go up. Many of these people have incontinence problem, as you must have seen.
Yes,
And
madam.
they have incontinence because the pelvic floor is affected. So right from day one, we have to teach them pelvic floor exercises and pelvic floor understanding, the cognitive aspect of it. They should understand that how can they activate their pelvic floor every time they breathe. If you teach them that from day one, then they are less likely to have urine and fecal incontinence problems.
Okay. So, madam, in that case, since pelvic floor has a very important role with the breathing, so in any of the exercises we are teaching to patient, the first and foremost is we teach them pelvic floor activation and then move onward to the further exercises.
Yes, we should make them understand that the breathing and the diaphragm and the pelvic floor are very much part of a abdominal canister and they always move together. So if we teach them breathing, we never talk about pelvic floor. And that is why I've taken up this topic today, because we could have cardiorespiratory therapists in the audience and we could have a pelvic floor therapist in the audience. Both have their territory and we don't look at the breathing. If I'm a pelvic floor therapist, I don't look at the breathing. And if I'm a respiratory therapist, I don't look at the pelvic floor. But actually, we should combine the two and teach them the correct breathing pattern, how both are symbiotic. Also, as I said in the beginning, orthopedic knowledge and manual therapy techniques are very important for a cardiorespiratory therapist or for a pelvic floor therapist. So the whole abdominal canister, if a psoas muscle is weak or psoas muscle is tight, whether quadratus lumborum is tight, whether your piriformis is overactive, whether your obturator internus is, all of this assessment. So it's a big assessment. It's not, it's almost the whole body assessment that we have to do. And then one by one, treat, then the improvement in the pelvic floor dysfunction or the pelvic floor function is much better. And so is the improvement in the respiratory function of a person affected, like, for example, in asthma.
Okay. And madam, we have one more question. What have to be considered for male patients of COPD?
Male patient, what do we consider meaning?
If
Uh,
for this same for the breathing techniques and the pelvic floor, the
yes,
question
same.
is what
Yeah,
about the
yeah.
male patients?
Same. They also have a pelvic floor. They
Okay.
also have to be taught pelvic floor exercises. Okay.
Yes, yes,
Yeah.
yes.
So and we get nowadays a lot of people with prostatectomy done post surgery of the prostate, and they land up with urinary incontinence. So they have to be taught the pelvic floor and the breathing again. So yeah, we do treat a lot of male patients also with pelvic floor problems, because many of them have pelvic floor problems, many of them have breathing problems, and therefore the combination of the two is very important.
Madam, the next question is, do you consider infrasternal angles in rehabilitation of these issues?
Yes, yes, of course, very important when we are examining. If you notice those hands, see, in a webinar, you cannot go into details of everything. Some of the things we expect that we know, infrasternal angles are important. And on examination, we find out whether the obliques are working excessively from the angles that we, on examination, we can find out. Yes, they are very important.
Madam, the next question is, how do we consider pelvic floor muscles or core strengthening with arthritic patients of knee joint?
So pelvic floor muscle training with arthritic I teach pelvic floor exercises to all my patients. Maybe because I'm a pelvic floor therapist, but I'm telling you that even if a knee patient comes and you teach them, their stability improves a lot. And isn't stability important for solving some of the weight-bearing issues on a knee joint or an ankle joint or a hip joint? So yes, I would teach them posture, breathing, everything is very important. It's not unrelated. So if they have a bad posture, they're more likely to put more weight on the knee and get osteoarthritic changes further. So I improve their posture, I improve their breathing, and I would look at the pelvic floor muscles, and all of this put together helps them to recoup from the knee pain.
Okay. Madam, next question is, how do we confirm that the patient is doing exercises correctly?
Which exercise? It has to be a specific
the breathing
exercise.
and the pelvic floor activation.
Breathing, you put your hands, you cue, touch is the most important thing, right? Yeah, so you touch, whether they are doing lateral costal, whether they are put your hands on the abdomen, or they're using too much of the upper chest breathing. You put your hands, observation, putting your hands on the patient and talking to them and making them do longer exhalation, twice the amount of the inhalation. All of these things, that's how we know. And you said about pelvic floor muscles?
Yeah.
Pelvic floor muscles
Pelvic
also
floor
they asked?
activation.
Okay. So pelvic floor activation is best judged by a digital internal palpation. Okay. So, so I would tell them to squeeze around my digit. Okay. And I should get a cranial and a pubic lift. So lift of the pelvic floor towards the head and towards the pubis. And I can grade it. I can grade it like we grade our other muscles. This is also a muscle that can be graded. So it could be 0, it could be 2, it could be 4. Similarly, I would grade it. So internal palpation is the best method. And of course, we have biofeedback machines that can be used for judging the, but in clinical examination and treatment, digital palpation is the best method. Of course, it is subjective, it is not objective.
One more is there. Madam, what would be the frequency or repetition of exercises we will suggest to patient for pelvic floor activation?
Depends on when you say activation, I assume that they have a weak pelvic floor. There's a lot of controversy whether you should tell them to do 100 times in a day or whether they should do it just a few times in a day. There's a lot of controversy. Research is still, very controversial. So what I tell them is do it 3 to 4 times a day and be aware of your pelvic floor. For example, when you're lifting something, what is happening is there a downward movement of the pelvic floor because the weight of what they're lifting a cooker, in the kitchen. So when they're lifting it, can they activate their pelvic floor and do an action? So it should be converted into ADL. When they are walking, can they do intermittent pelvic floor exercises while they are walking? It should not be tightened and you're walking all the time. Okay, it should be a contraction and a relaxation. So both the things. So basically, pelvic floor training is a lot of cognitive, and of course we have weights and we have all these gadgets that can be used to train them further. As I said, biofeedback, but incorporate into ADL activities is what I emphasize on, and different positions. In every position, they should be able to activate the pelvic floor in crook lying, in quadruped position, in standing position. So you assess them, side lying position. So you assess them in different positions. Is she able to activate a pelvic floor? Because some of them can activate in one, but cannot activate in another.
Okay, thank you, madam. I think we come to an end of the question sessions now. Okay. Thank you so much, madam. On behalf of entire IAPWC team, Rajkot district, Gujarat, I would like to express my heartfelt gratitude to you for sharing your time and valuable experience with us. It was a beautiful session, and thank you once again for your valuable contribution to us. I thank all the attendees for attending this webinar, and we look forward to bring to you many such more. Thank you, everyone.
Thank you. Thank you so much, Vaibhavi. Thank you so much, Alopi. And thank you so much, IAP WC Rajkot and the whole of IAP. It was wonderful to do this webinar.
On behalf of IAP technical team, I would like to thank Dr. Snigdha ma'am. Ma'am, it was a really amazing session. The chat box is full of vote of thanks and all. One participant request to you, please do one more session on this. So it is actually such an informative webinar. Thank you so much, ma'am. I would like to
Thank
thanks all participants. They can join and make it successful. So thank you so much. Before end this session, my big extent, my sorry, my hello. Yes. Before end this session, I really thanks to Dr. Ruchi Vashne ma'am, our IAP Women National Head, and IAP President Dr. Jha sir for provide us a platform for the sharing knowledge. So thank you so much to all, and I request to all participants please subscribe our IAP YouTube channel. Thank you. Thank you, ma'am. Thank you, Vaibhavi ma'am.
Thank you, madam.
thank you. Thank you.